All right. Welcome everyone to the American Indian and Alaska Native Behavioral Health webinar series. I'm Lena Thompson, and today John Jewett will be speaking on integrated care and its role in early identification of substance abuse. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of four national centers serving the ATTC network shown on this slide. The network also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The CEH form is available for download in the Files pod in the webinar screen, and I will also be sending this form in a follow-up email to all who will be attending. The pod is in the bottom left-hand corner. Immediately following today's webinar, you will be redirected to our Gipper Evaluation Government Performance Results Act form. SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. Before we start today's session, I'd like to go over a few instructions for the Adobe Connect system. To view the presentation in full screen mode, click on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to regular view, click the button again. You will be muted for the duration of this webinar. Please use the question and answer pod to share your questions and comments, and we will address questions at appropriate points during the presentation. Today's speaker is John Jewett. John is the Behavioral Health Manager at the Sandia Pueblos Health Center. He is a member of the Oglala Sioux Tribe and a nationally certified counselor. He has worked for international, national, and local nonprofit organizations. He is an expert in Indian child welfare and is a graduate of the Addiction Technology Transfer Center's American Indian Leadership Institute. John, thank you so much for joining us and for sharing your expertise with us today. I'm going to go ahead and pass things over to you.
Hello everybody, and good morning or good afternoon depending on where you are in the country. Today I just want to talk to you a little bit about integrating behavioral health into our primary care setting. And I did this when I worked at the Denver Indian Health and Family Services when I was in Denver at their urban Indian facility. And then we've also begun to do this here in Sandia. Mostly because integrating behavioral health with primary care is just a really important idea with regard to helping to address the health and wellness of the entire person. So, like Lena said, I'm John Jewett. I'm a licensed professional counselor and also a certified addictions counselor. Currently the behavioral health manager at the Pueblo of Sandia. And so I want to talk first about what's the mission of integrated behavioral health. So the mission really, as you can see, is to improve the behavioral health of the population through the integration of mental health and substance abuse screening and into the daily provision of primary care. And of course, this is to improve both the physical and the emotional well-being of our patients. And beyond just connecting them in the primary care setting to behavioral health, we also really are looking at resourcing them and doing more types of work that most people would think a social worker might do in terms of connecting them to the resources that they need to be healthy as well. From the primary care perspective, they appreciate integrating behavioral health into their work because it helps support the self-management of patients. Maybe they're chronically ill patients who are depressed, and being able to address their depression will help them to better manage the medications that they're on for their chronic health issues. Finally, and like I said, improving treatment adherence and compliance, and people in primary care see the addition of behavioral health screening and treatment as a real add-on into the interventions that they're able to already do. So when we look at integrated care, there are a lot of different models that we can have. So in the way that most places have traditionally worked, you'll see at the top it's called a separate space model. And this is where behavioral health is located in one facility. And it may not even be close. It may be across the reservation or in an urban area. It may be at a completely different organization. And then you've got behavioral health in one area, and then primary care in a completely different area. And then, and in the beginning, really the two didn't really talk a lot. But then as we've evolved, now then you have this next level, which is sort of a one-on-one referral relationship where you have some exchange back and forth. So as a clinician, if I were to, if somebody were to sort of talk to me about maybe having some symptoms for sleep apnea, then I might refer them back to their primary care provider. And the same way, if somebody were depressed, they might reach out if we had a relationship to refer them to the behavioral health facility. The next level down of integration is co-location. And co-location really is where you're both on the same site, but you really are separate teams, and a lot of times that ends up being silos, and there isn't a lot of communication. The next level is where you move to collaborative care, where you're located at the same place, you know you're seeing the same people, and because of that, you actually move towards sharing cases and talking, so that physicians and nurse practitioners are talking with psychologists and professional counselors and marriage and family therapists and social workers on the different cases, including psychiatrists as well. The last and the most integrated is what they're calling fully integrated, which is where you literally have a behavioral health clinician embedded on the primary care team. And so there's usually a dotted line report to the behavioral health manager, but that person, that behavioral health clinician is literally located in primary care and sits there, and their primary position is to address behavioral health screening and behavioral health issues in the primary care setting. And so the ideal level of integration for patients is that fully integrated level where they can go to one place and receive the services that they need. So for a lot of systems, this is a completely new idea, and so there are a lot of clinical barriers that can come up. One of them is just that traditional piece that I was talking about, where there's a separation of mental health from primary care. The two really aren't used to talking. Maybe there's some folks in behavioral health that aren't really crazy about the medical model, and then there are some people in primary care who really don't receive a lot of training about behavioral health, and so they're just not really familiar. And so people traditionally have just gotten comfortable being separate, and so this is a new idea for people. When we look at another clinical barrier is the lack of awareness in terms of mental health screening tools. And so, yes, people in primary care would actually like to screen for substance abuse issues or mental health issues in the primary care setting, but they really don't know what the tools are that would allow them to do that. And then finally, many physicians have limited training in psychiatric disorders, and so they're not as comfortable working in the behavioral health area. And so part of the challenge in the clinical barrier is to help the physicians and the nurse practitioners become more comfortable working with substance abuse and mental health issues. Then there are also financial barriers, and so some people might think this is a really great idea, but the systems like Medicaid reimbursement and insurance reimbursement are pretty far behind with regard to how they're structurally set up to bill. So in many places currently, for Medicaid, you're only allowed to bill for one visit. And if it's a primary care visit, you can bill for that. But if you have a behavioral health visit on the same day, in some states, you're not allowed to bill for both. And then in other states, you are actually allowed to bill for both, but they have to be separate visits. And so you'd have to go down to primary care, and then they'd literally have to walk you over to behavioral health, and then you could count both visits and get paid for both visits. So that if you have an integrated system and you're doing integrated care in your primary care facility, and you have a behavioral health clinician come into primary care, then there currently in many places is not a way for you to bill for the service that the behavioral health clinician is providing in that same visit. So that's the financial barrier there. So we've talked a little bit about the policy barriers. Also, the challenges with sharing information due to HIPAA. As most of you know, and in most states, the confidentiality associated with substance abuse is even higher than it is for mental health. And so when it comes down to sharing information across systems, it gets more difficult because in some states, let's see, the physicians are not supposed to be seeing the notes of the people when it's a substance abuse related issue. And so again, as we want to get integrated, but some of these systems and some of these policies become barriers to the kind of care that we know we really want to give people. In many places, there are organizational barriers like a shortage of mental health professionals, especially in rural Indian country. And then get sort of back to that idea about limited communication between medical and mental health providers, because we really have to be willing to move a little bit outside of our lane in order to be good team players and to support people's physical and emotional well-being. And then finally, of course, the policy things have to be put into place. Like it has to be a part of your job description if you're going to be moving into integrated care, so that, let's say you're not particularly passionate about it, you would still want to make sure that it's a part of somebody's job and that they know that that's a requirement to do the integrated care piece. Finally, we talk about why is integrated care important, and this is from the medical model. So if you look at this diagram and you look at what big of a role major depression plays in chronic pain, strokes, diabetes, heart disease, you can see that having major depression has a significant clinical impact on the treatment of these conditions. And so this is where the behavioral health outcomes and the primary care or physical health outcomes really dovetail, and we can see it in a big way. Just like when we looked at the ACEs and the ACEs studies with kids, and we know that now they've shown this huge, tremendous correlation between the number of ACEs and physical outcomes for people, early mortality and things like that. Now they're looking at the same thing with behavioral health and looking at actual behavioral health conditions and how they impact medical conditions. So another reason this is important is because people have done a lot of research on this, and you'll find a lot of this information on the SAMHSA website. But primary care really has become the first line of treatment for mental disorders. They will visit their primary care providers much more than they will just look in the phone book, for instance, and try to find somebody who is a behavioral health professional. They usually already have a relationship with the primary care provider. And so that's where people will, as you know, will go in and talk to them about, I'm not feeling myself, or I'm feeling a little anxious and things like that. The integrated healthcare also helps to reduce the stigma of seeking mental health. And so, especially we know in Indian country, there can be in places a lot of stigma about not wanting to be seen as going to the behavioral health or mental health for mental health treatment. Having it in an integrated care, people, even if people are watching people go into the clinic, they're going into a health clinic. And so if within the context or in the space of that visit, they have a visit from somebody who's doing primary care and from behavioral health, we're just reducing the stigma for folks that are concerned about walking into a behavioral health clinic. Then I addressed this a little bit already, but the psychosocial distress corresponding with the mortality risk. And finally, this is a really positive move, I think, for all of us in behavioral health, which is that the medical community is becoming more and more accepting of not only the impact of behavioral health on health conditions, but they're also becoming more accepting of dealing with that through the use of integrated care. So here's just some stats for you. Approximately 70% of all visits in primary care involve psychosocial factors. And again, primary care providers are the de facto mental health and addiction disorders providers for over 70% of the population. In some cases, it's just because clients are not connected to behavioral health providers, and in some cases, in rural areas, they have a shortage, and their primary care providers really are the ones who are managing their depression or anxiety through medication. And then close to 80% of patients with depression go to their primary care physician first. And I think this is really significant, especially when we look at suicidality. It's so important for our systems to be able to catch people with depression as early as we possibly can. And knowing that 80% of patients with depression go to their primary care physician first just tells us really the first place where we need to catch this is in the primary care setting. And then finally, and this won't surprise a lot of us, that mental health diagnoses often go unrecognized and untreated then in primary care. And also in primary care, many of the times people will undertreat. So they will offer people medication for anxiety, for instance, but they won't offer to send them to treatment with a behavioral health care provider. So how does this work? People are probably wondering, okay, so yeah, we like the idea about integrated care, but how does it actually work? What actually happens? And so when we're talking about integrated care, behavioral health providers are called in as needed to provide services like an assessment, to do care planning and coordination in terms of helping them to access the behavioral health care that they need, patient navigation services. And so in many places, there isn't a lot of case management support. And so the behavioral health clinicians really, when they're working in a primary care environment, are looking at the patient across a multitude of systems to help them navigate all of those systems. And then, of course, the clinician is there for patient and family support, especially in the case of children, because if there's a child that's depressed or anxious, somebody who's comfortable and who's familiar with the issues and who's comfortable talking to parents will need to go out and be able to talk to the parent about what type of family support the child might need. And then finally, of course, the core of the work is really doing the psychotherapy piece of the clinical intervention. Sometimes it might be referring somebody out for those services. In some places, if they think that people just need a little bit of support, maybe they can do it in one session or 3 or 4 sessions. And the integrated care clinicians really become experts in finding out what people need when they come through the door. So this is a little challenging to see, but the way that it works is that in primary care, they develop a screening tool. And the first part of the screening tool at the top will assess life areas. And so it has things like, and it's a Likert scale that goes from completely dissatisfied to completely satisfied. And then there's a doesn't apply column in case something in that doesn't apply. But so it'll ask things like where you live. Are you completely satisfied or completely dissatisfied or somewhere in the middle of those? And these are questions that help physicians in primary care and nurse practitioners. It helps them to have a dialogue because as we've all probably experienced, some physicians and primary care providers are very personable and know how to have a warm dialogue with their clients. Others, it's not a skill set that's particularly strong for them. And so screening for life areas and challenge in life areas actually gives physicians an opportunity to talk to their clients about things other than the particular presenting issue that they've come in the door for. Then if you go down a little further down the form, we use a PHQ-4, which is actually 2 questions on anxiety, and 2 questions on depression. And I think they've attached our as handouts, they've attached the actual screenings that we use. And on the back side of the screening is a score sheet that you can use to determine how we actually assess these things. If you move further down, and a lot of you are familiar with Gipper, you'll understand that we're asking some of the same questions. And so some of the questions are about violence in their relationships, and then others are about, in particular, for issues among seniors. And so I know this is true in Pine Ridge, where my family is from. Also, true on other reservations where they have casinos. And so we ask what's called a lie bet, which is to rule out addiction to gambling. And then we also go on to ask one question about drug abuse, and it's really simple. Have you used any drugs, illegal drugs in the past year? And that's really a yes or no when it screens in or out. And then some people use the cage, some people use the craft. We use the ATTC, just whatever your clinicians are comfortable with in terms of trying to catch the substance abuse issues early. And so the whole purpose here at Sandia, primarily the substance abuse piece was the driver, because what we were finding is that most of the treatment that was happening and most of the energy was being spent on addressing challenges with the substance abusing population after they had gotten into the court system. And of course, that's far too late, because it becomes really challenging at that point to work with all the various issues that are going on. And so we introduced this in primary care so that we could hopefully catch people earlier when they were starting to do some binge drinking. So it sort of documents the frequency and the intensity of their drinking. Let's see. At the bottom of the page, there's a question, if they've responded, and the nurse practitioner or the MA or whoever you might have in the primary care clinic scoring this, if they've determined that there is a positive result, there's a question at the bottom that really just says, hey, we have somebody in our office that can work with you on some of these types of issues. Would you like to talk to them? Some people use that last question and then others don't. So before I go on, I want to give credit to the University of Colorado Children's Hospital, who developed a lot of this when I was in Denver. And then since moving to Sandia, we've just added, we've changed the substance abuse piece, and then we've added that part, the lie bet, which is to assess for gambling issues. So as we look at thinking about, well, gosh, where do we even start? How do we move in this direction? The first piece of this is securing leadership's commitment, because we have to be educating and preparing and motivating staff for change, because if you don't bring everybody along, you're going to have people that are resisting any kind of change. Another important piece is, for people that don't know a lot about this, if you give them job shadowing experiences. And so when I was in Denver, we sent our nurse practitioners to other clinics where they were doing integrated care so they could see how it worked. And these were places that were seasoned and experienced at doing this. And so they were able to see it play out on a daily basis in a way that was really organized. And then the same thing with the behavioral health care clinicians. We would send the behavioral health clinicians to shadow places where other clinicians were already doing this work in primary care, so they could see, what the role was and what they were supposed to be doing as a behavioral health clinician. Finally, integrating electronic medical records. It is near to impossible to have integrated care without using electronic records that are shared between primary care and behavioral health. They make all of the difference in the world, because so much of the communication that can happen, people can read the information about what's happening in the other areas. And then when we spend our time and we meet every other week with our primary care providers, going over cases to talk about how what they might be able to do something in primary care to help benefit a client who's not responding to to maybe IOP, and maybe we'll decide that we want to try Vivitrol or something like that. But without having those electronic medical records pieces, you'd really have to spend a lot of time in those meetings. Instead of talking about what to do, you'd have to spend a lot of time figuring out what's going on with a particular client. The next piece is once you've got everybody on board and you kind of have everybody knowing what this is, and they've been out and they've been able to see it in the real world, then you're going to have to really look at preparing your back office and looking at what makes financial sense. Are you able to, do you have the staff to be able to do this? So in Denver, since I've left, they've actually been able to hire a full-time clinician who's located in primary care. But prior to that, we were using social work interns to do the behavioral health interventions in primary care. So there are lots of different ways that you could set this up. Here at Sandia, we all have a little more time as clinicians, and there are 4 of us, and so we're more available. And so when they have somebody in primary care that needs some behavioral health support, they actually will come down and they'll let us know that they're there, and then they'll let us know whether they want to see us or not, and then we'll go down. Writing the plan, making sure that everything is really concrete, everybody knows what the goals are and the objectives are. And then the last part is that we want to weave it into people's job descriptions so that they know that it is a part of what they are supposed to be doing at your organization, and that it matters enough that it's being put into your job description is something that's important. And then finally, you'll want to look at developing materials to capture data, because in these days and times, people always want to know how this is working, and we always have individual stories where we can, talk to them about how well this is working, but people really want data. They want to know, how many people have you seen? Of all of those people, how many people did you give the survey to? Of all the people that had that assessment, how many people did you actually end up seeing? And then how many were referred out, how many were treated internally? And so we have to do all of that kind of thinking prior to implementing integrated care so that we're ready to capture that data to support the work that we're doing. So at both places in Denver and also here, we did a pilot project because we wanted to find out what the different needs were of our population. So these are 2 very different populations that I'm working in. The first population was Denver, and there were a lot of poverty-related issues and a lot of systems navigation issues because Denver was so huge and people just didn't know how to access all of the different things that their families might need. And here at Sandia, it's less of an issue about poverty issues, but we still have issues related to family and doing more family work and things like that. And then finally, we're going to integrate or finalize the integrated care plan. And that means looking at those things that I was talking about. How are we going to do this? So Sandia's model is we use existing staff. At Denver, the initial model was using interns, and then they've been able to get a grant to pay for a clinician who's located in primary care. So at this point, I think we should just take a look at what is he talking about? You're probably wondering. We could take a look at how this actually works in a clinic.
Medical assistant quickly scans the annual screen and gives a full screen to patients who score positive.
Here's an additional form for you to fill out. Please give it to Dr. Winkle when you finish.
Okay.
Thank you.
The full screen is a 10-item questionnaire that places substance use into categories of low risk, risky, harmful, or dependent.
Hey,
see you.
Good to see you.
So you're here today to follow up on the migraines, right?
Correct.
So in the last 6 weeks, how have those gone for you?
I'm still getting them.
As part of the visit, the clinician addresses the full screen. So, Alex, we have you on a new medication plan for the migraines. You have any questions about it?
Nope.
Great. So before you leave here today, I saw that you took the time to fill out one of our alcohol screening forms. Thanks for doing that.
Yeah.
Is it okay if I look at it with you?
Sure.
Okay, let's have a look. All right, here. So, answers on the full screen are totaled, and a category of use is circled at the bottom. Okay, so when I total your score, based on your answers here, it looks like you score into a zone of use we call risky.
Really? Because I don't drink that much. It's not a problem.
So your drinking doesn't seem like a problem to you?
No.
Okay. Well, I tell you what, if you're open to it, a colleague of mine here is great at talking with patients who typically score into this category to help them decide if they want to do anything about their drinking or not. That way, I'm just making sure I'm providing you with the best care we can. If it's okay with you, would you be open to me introducing him to you?
Sure.
Great. Well, I'll be back in a minute with Demo. Thanks. The clinician performs a warm handoff to the behaviorist. Alex, this is Demo.
Hey, Alex.
And Demo, Alex filled out one of the alcohol screening forms and said it was okay if you came in and talked about it with him.
Is that okay with you?
That'd be fun.
Great. I'll give this to you.
Thank you.
And Alex, I'll see you next time.
All right.
Great. Thanks.
Alex, we haven't met before. I'm actually one of the healthcare professionals here at the clinic. Do you mind if we review the forms that you filled out?
No, that'd be fun.
Okay. Can you tell me a little bit about your drinking?
I think I have a few drinks on Fridays.
And what do you drink?
The behaviorist performs the brief intervention. Under the medical home model of primary care, the receptionist, medical assistant, clinician, and behaviorist all carry out the Esprit clinic workflow.
Okay, so that was just a sample of what it can look like at a clinic when you do an integrated care visit. They get screened, as you could tell, and then they ask permission to bring somebody else in if there seems to be an issue, and then the behavioral health clinician takes over from there. And it's a way to, that's really how you're integrating primary care and behavioral health. So here are some of the lessons that we've learned so far, is that you have to have a strategic vision and it has to be supported by leadership. And in terms of making sure that you're always going to be able to provide this kind of service, we really have to create a sound business model and an infrastructure that will support integrated care. So I think I referenced this earlier, but as the systems are changing, like Medicaid and systems like that are changing to help better address getting providers paid for providing this kind of a service, we're just sort of waiting until these systems catch up with what we know is the best care for patients. It's also really important to address political and organizational issues and any philosophical resistance. And so I know that in some of the work that I did, I encountered more resistance on the part of behavioral health professionals than I actually did in primary care. But I did also run into some folks in primary care that really didn't want to deal with that behavioral health stuff. So making sure that you have the senior leadership in place and putting it into people's job descriptions is really important so that they know that this is a have to and not a want to. This isn't something that we do because we think it might be a good idea. It's something that we do because we know it's critically important for good patient care. The last piece, and I think we did a pretty good job with this at both places when we started integrated care, was to set up measurements and performance indicators so that we could document the progress that we were making and the impact that we were having. And then finally, in places where this is really important, especially in urban environments, identify funding sources and financing strategies that will make the project sustainable. So what are next steps? I mean, there are so many places that you could go with integrated care. So here we're looking at integrating dental referrals and doing the same thing. And so maybe the dentist is not able to come over, but maybe somebody from the dental clinic can come over and meet them and do a warm handoff. And that way they'll at least know somebody at the dental clinic. The next piece is, thinking even bigger and outside of the box in terms of integrating traditional healing into their practice. And so here we have people that are available on the Pueblo to be able to do that, and so it's a lot easier than doing that in an urban environment. And then at our clinic, we already have some complementary medicine, so we have massage and we have chiropractic care. And so we're able to do warm handoffs to those people, not just from the primary care clinic visit, but also on a behavioral health clinic visit. And so if I feel like biofeedback might be helpful, then I will actually take a client to the person who does biofeedback and introduce them on their way out of the behavioral health appointment. So this is some of the ways that you can actually evolve it to encompass more. And if you really take it all the way, you could begin integrating the personal trainer if you had that available to you or something like that, who might be able to come in and instead of the physician just saying, I think it'd be really important for you to start going to the gym and losing 30 pounds. You could actually say, I think it'd be really important for you to begin to look at what your goals are for exercise. Hey, we have a personal trainer that would be willing to come and talk to you about those kinds of things. And on our Pueblo, we're small enough that I literally just have to go across the parking lot to get somebody to make that happen. So finally, integrated healthcare is a coordinated, person-centered system of care that provides both the medical and the behavioral health services to address the whole person. And then I just want to give special thanks to the AIAN ATTC's Leadership Academy, because it was through the Leadership Academy that I actually developed this project to be able to do this work at Denver and now at Sandia. And I'm currently working with the Pueblo of Jemez to have them begin to do integrated care as well. So I guess at this point, I'll just be open for questions in case anybody has any questions about all of this.
Hi everyone, you can type your questions in the question and answer box over on the side. And if you're having a hard time finding that pod, or if something's not working, you're welcome to email me at Lena, Lena-Thompson, THOMPSON, at uiowa.edu, and I can pass those questions on to John and his email. I'm going to go ahead and pull up our wrapping up slides. Oh, I'm sorry, apparently we don't still do wrapping up slides. I just want to thank you so much, John, for being here today and for talking with us. It's always great to hear from you and to have you here. And thank you, everybody, for joining the Behavioral Health webinar. We're looking forward to seeing you again. Thanks, everyone. Bye.